Hello? No sound output on our end?
Hello, everyone. Thank you for coming to the meeting. Thank you for attendance here.
Yes, hello everyone. Good afternoon to you all. You are welcome to today's SEED Global in partnership with Means for Health EMS Echo session series about approach to an acutely present patient. I'm Makamba Bakar, a critical care nurse at Uganda Heart Institute, and I will be moderating today's session. Here with me is a team of highly knowledgeable and resourceful experts. Well,
Good afternoon, everyone. This is Dr. Harry Chen. I'm a C Global Health Educator in Emergency Medicine in Ambarara, and we still cannot hear you.
Okay, sorry for the interruptions. So next on agenda, we shall be filling in the pretest that will be displayed on your Zoom screens. And I humbly invite two individuals from the audience to share their expectations for today's session. Thank you. Meanwhile, you can be filling in and other people raise their hands in the chat so that they echo out their expectation about today's session. Yeah, so let's have two individuals from the audience to echo their expectations about today's presentation. Kindly raise your hands in the So let's have Albert Bonsu kindly speak. Unmute and speak.
Good morning.
Good afternoon.
Hello.
Yes, we can
Oh,
hear
good
you.
morning. Okay, my name is Albert. My expectation for this program is early recognition of the signs and symptoms and the treatment modalities.
Okay, thank you so much. Let's have Job Masiliwa. Kindly unmute and talk to us.
Thank you and good afternoon. I hope you can hear me. My expectations for
Very
this.
well.
Okay, thank you. My expectations for this session is for the presenters to point out the commonest causes of poisoning in our setting, their emergency management, like the steps that we can follow in managing them. Thank you.
Thank you so much. So I further invite you all to actively participate, ask questions, feel free to supplement throughout the presentation so that we learn from one another. So at this juncture, allow me to invite our case presenter, Dr. David Mirumbi. Thank you so much.
Yes, good afternoon, colleagues. Once again, I'm called Dr. David Mirumuvi, and I'm presenting our case. Our case for today is OP, a 28 years male border rider, who was admitted to Mulago National Referral ED on the 4th of this month and presented with excessive salivation, sweating, vomiting, diarrhea, and altered mental status. OP was brought in by relatives after drinking a bottle of Striker. Striker is a common pesticide that is used in Uganda. And this was following an altercation with his brother, which they had during a land wrangle. So he presented with excessive salivation, sweating, vomiting, and diarrhea. And he became increasingly weak, confused. He developed muscle twitching and difficulty in breathing, which prompted his relatives to rush him to the hospital. Upon arriving at the hospital, we did our primary survey, and in the airway was obstructed by excessive secretions, but the gag reflex was intact. At this point, we did suctioning of excessive secretions. We considered intubation, but we didn't do it. When we assessed his breathing, he was in respiratory distress. He was tachynic, and his respiratory rate was 28 breaths per minute. He was wheezing, and his SpO2 at room air was 88%. At this point, we put him on 10 liters of oxygen via a non-rebreather mask. We also nebulized him with salbutamol. When we did his circulation, his blood pressure was 90 out of 60 millimeters of mercury. His heart rate was 55 beats per minute. His capillary refill was delayed by was more than 3 seconds. At this point, we inserted 2 large bore cannulas. We took off samples for investigation, CBC, RFTs, LFTs. We did serum electrolytes. We gave him a bolus of saline, 500 mils for the hypertension, and we started atropine, 2 milligrams IV bolus, and this was repeated every 5 minutes. Disability, his Glasgow Coma scale was 11 out of 15. Motor, we gave him 5. Eye opening was 2, and verbal was 2. He was confused, but he was responsive to pain. His pupils were pinpoint. RBS was 7.2 millimoles, and he also had muscle fasciculations. At this point, we gave him IV diazepam. We gave him IV phenytoin. We passed an NG tube, and we also passed a urinary catheter. We exposed him and we took auxiliary temperature, which was 38.2. He had no life-threatening injuries. His clothing and skin was contaminated with a pesticide. The vomiters had a strong odor of this chemical. So we removed the contaminated clothes. We gave him IV paracetamol 1 gram. Then at this point, someone attempted to give him activated charcoal, but he was advised that it was already more than an hour since he ingested. So he appeared significantly ill. He was diaphoretic, excessively sweaty, agitated, and in respiratory distress. The clothes were smelling, the chemical which he had taken. He had some dehydration. He had mild pallor. He was not jaundiced. He was not cyanosed. He had no edema, and he had no lymphadenopathy. Cardiovascular, the heart sounds were normal. Peripheral pulse was weak, but palpable. On the chest, respiratory system, the chest was normal shape, no tracheal deviation. There was equal air entry with bilateral wheezing. He was using accessory muscles, and the chest movements were reduced bilaterally. For abdomen, the abdomen was moderately distended, but moved with respiration. It was soft, non-tender, and the bowel sounds were hyperactive. The ENT, he had no nose or ear discharge. CNS, GCS was 11 out of 15. PPUs were pinpoint. He had muscle fasciculations in the arms and legs, and then he also had generalized muscle weakness. The musculoskeletal system was unremarkable. The sample history, his symptoms were summarized as salivation, diarrhea, vomiting, muscle weakness, twitching, seizures, respiratory distress, and altered mental status. He had no history of allergies, no chronic medication use. He smoked occasionally, and he had no history of alcohol consumption. He had no previous history of a similar episode, and no family history of neurological or cardiovascular diseases. About his last meal, it was unknown, but definitely he was at a risk of aspiration from vomiting. The event that led to this incident was he attempted suicide by ingesting a pesticide called Striker, following the altercation with his brother about land. And approximately 1 hour after ingestion, he developed excessive salivation. To the hospital, he was confused, he was convulsing, and had difficulty in breathing. The problems at admission that were noticed is that he was in distress. His mental status was altered. He had seizures. He was bradycardic, diaphoretic. And we did renal function tests. We did liver function tests and electrolytes, and largely they were insignificant. But we also went on to do an ECG, which showed sinus bradycardia, and we never had an opportunity to do a chest X-ray to rule out aspiration pneumonia, and we didn't do the arterial blood gases. The immediate interventions we did were suctioning of the excessive oral secretions. We gave him 10 liters of oxygen by a non-rebreather mask. We gave him IV fluids, 2 liters for the hypertension. We nebulized him with 5 milligrams of salbutamol in 3 mils of saline. We gave him atropine, 2 milligrams IV bolus, which was repeated every 5 minutes until the secretions dried up. We gave him IV diazepam, 10 grams for the twitching. Then we gave him IV phenytoin 500 milligrams start for the seizure. On the second day, his GCS decreased to 8 out of 15. The blood pressure was 92 out of 55. The pulse rate was 65, and the secretions had reduced. He was given IV omeprazole 40 milligrams. The atropine was continued. Phenytoin was continued. They gave him IV safe, and they maintained 1 liter of fluids. He was monitored for the random blood sugars, BPs, SpO2s, temperature, respiratory rate, and pulse rate. A repeat RFTs and electrolytes were ordered. The disposition plan at this point was to admit him to the ICU, monitor for delayed symptoms, do patient counseling, do psychiatric evaluation. And unfortunately, on the 6th of February, this patient passed away on at 11 hours before being transferred to the ICU. That's our case for today. If there are any questions, I'll be glad to take them on.
Thank you so much, Doctor, for your well-elaborated presentation. At this point, we are welcoming any reactions, any questions, any supplements from our audience, and we can start with our panelists in case they have any. Whoever is interested in supplementing, kindly raise up your hand, or we have an active chat. Keep on sending your supplements and questions through the chat. Thank you so much. Yeah, if there are no questions or supplements,
okay, thank you. My question will go to the point where I was talking about activated charcoal. Then it said someone was advised not to give the activated charcoal. Could you briefly tell us in which timelines do we give the charcoal? Thank you.
okay, thank you. Yes, Doctor.
When we're managing poisoning, charcoal is not indicated for all types of poisoning. Yes, as we shall see from our presenters, charcoal is indicated for certain groups of poisons, and in others it's not indicated. But for this case, charcoal was supposed to be given within our 1 hour presentation. After 1 hour, then it will have no significant impact on the outcome.
Okay. Thank you so much, Doctor. So at this time, allow me to invite our next presenter, who will be taking us through the toxicological history, epidemiology, clinical presentations, and the different toxidromes in acute poisoning. And that's Dr. Dickson Kamoga. You're most welcome.
Yeah, thank you. Once again, my name is Dickson Kamoga. I'm an emergency medicine resident at Makerere University. My talk today is going to be about an approach to a patient with acute poisoning. So the case that David has just taken us through was for a patient who had an exposure to organophosphates. So these are the typical patients that we usually see and manage in our emergency departments, and it could be that patient that you could encounter in your pre-hospital environment. So it's crucial that you have a generalized approach to managing patients who could present like this. So this talk is going to give us an understanding of how we approach these different situations and how we usually, get the patients out of trouble and disposition them to the right departments where they'll get appropriate care. Yeah, so maybe just to echo something, just to briefly answer the question of when charcoal is actually safe in these patients. So like David has said, it's not every poisoning that you give charcoal for. So it should be those particular toxins that you're sure can be bound by charcoal to prevent reabsorption in the GIT. And also the time frame within which the patient presents is very critical to decide whether to give them charcoal or not. So that patient has to have presented early. Another precaution to take is that the patient's airway has to be protected. So that means you're going to consider giving it to either a conscious patient or a patient who is having an NG tube in, because the risk of aspiration has actually been very bad when you give these patients charcoal and they're unconscious. So they sort of tend to regurgitate what's in their GIT and aspirate it in their lungs. So key precaution is that these patients really have to have either an NG tube in or their airway protected, of which they probably need to be conscious. So about my presentation, I'm just going to, again, go over just a generalized approach to these patients. I have no issues to disclose in this talk. These are the intended learning outcomes for my talk. So I'm expectant that at the end of this talk, everyone that's listening in should have an understanding of the global burden of poisoning, and also really some local contextual statistics of how we're dealing with toxins in the country. So the other thing is I would like at the end of this talk, every participant to have a generalized approach really of how to manage these patients. So just some definitions. Yeah, acute poisoning is simply an exposure, either intentionally or unintentionally, to a toxic agent that could have, complex pathophysiologic changes to the body, leading to a disease process that usually manifests as a toxidrome. So any agent that's potentially harmful to either the cells or the physiologic processes of the body could potentially be a toxin. So meaning that all agents, all the drugs that we potentially give, that we give patients can potentially be toxins based on what doses you're giving them in or what routes of administration that you're using. So lots of things that we get exposed to on a day-to-day living are actually potentially toxins. What creates a distinction is how we administer them or how much of them we get exposed to. So commonly, poisoning is actually intentional. So studies have found that most people that present with poisoning to hospitals actually did intentionally expose themselves to the toxins. And it's commonly because of a psychological issue that probably got them acutely stressed, and they felt no need to continue living. So they intentionally take a drug to try and end their lives. But then we also have a category of those that accidentally get exposed to toxins. And commonly those are children who are really non-suspicious, but they could just pick up drugs that are just kept within their reach and they take them. So that could potentially cause them, to be poisoned to those agents. All right, so let's look at some numbers here. So globally, like I said in the previous slide, most toxins, poisoning cases are actually intentional. So, and globally, we tend to see that intentional exposure to toxins causes about 1.34% of the global deaths. And that's really higher than the unintentional ones where people just get exposed accidentally to toxins, which account for about 0.4% of the global causes of death. So locally, what we see is that most of the poisoning cases that we encounter in this clinical setting is actually organophosphate poisoning. Organophosphates are commonly found in the pesticides that usually are used in farm work. So most people, tend to expose themselves to them unintentionally because they were probably spraying, a garden, and they accidentally inhaled these organophosphates into their system. So they might present, acutely poisoned, but because they were, they didn't intend, they were just working, but they got, they inhaled organophosphates into their systems. So also globally, we see that females are more likely to be poisoned compared to to males, and that commonly most people that present with poisoning to hospitals are due to, they have an underlying psychiatric disorder that probably impaired their mentation, and they got an hallucination and they swallowed an agent that was potentially toxic. So in Uganda, there's not so much data about poisoning, but a few studies that have been published out there report really what alludes to the case that we've seen in this talk, which was organophosphate. So studies have found that most cases of poisoning in Uganda specifically are due to organophosphates, and males are really more involved. That's kind of contradictory to what the global picture reports, where females are more commonly involved. Surprisingly, most cases that have been reported in Uganda, according to the meta-analysis that I quote up there, were in Ankoli, and children below 5 years were more exposed, are more at risk compared to other age groups. So common toxins that we might encounter in our practice, I've just really listed these agents here. And again, these could be the ones that your patient might present with. Our case was organophosphate, so it's the commonest, it's what statistics have reported. However, there are other agents that patients could be exposed to, and some of these things are snake venom. So if someone is bitten by a snake and it inoculates venom in their system, could potentially cause pathophysiologic processes in their body that would, cause derangements in their physiologic function. So other agents could be, things that we use in the day-to-day life, like bleach. We use to wash clothes, kerosene, petroleum. Then also commonly, some people tend to get exposed to carbon monoxide, as usually in house fires where they probably interrupting, and by the time they were evacuated, they had inhaled enough carbon monoxide or even cyanide. So another key point to note here is that most prescription drugs that we use could potentially be toxins, depending on how they're used, how long they're used for, and what doses. So all agents, but the ones that we tend to commonly see in practice are really the antihypertensive medicines, are the drugs that have effects on the CNS. So things to watch out for patients who are poisoned is agents that we use, like calcium channel blockers, opioids, beta blockers, digitalis. Again, some alcohols are also potentially toxic, like methanol alcohol. All right, so they should be, yes. So this is just an illustration of how we approach a patient based on their initial presentation. So when you do the quick evaluation of a patient whom you suspect to be poisoned, they could fall in one of the two categories. They could be vitally stable or they could be unstable. So the initial approach really is going to depend on that initial clinical evaluation that you're going to do. If they're stable, again, the same principles apply for managing all patients. Look for the cause, take your time, monitor them, and you see if they're deteriorating or not. But if they're unstable, then the initial goal is to start resuscitation, then look for the actual toxin they could be exposed to after getting them out of the immediate danger. It means like fixing their airway, fixing their circulation, fixing their breathing, then just go on and look for the possible causes of the poisoning. So yeah, this is why I was just explaining. If they're unstable, go on and do an ABCD, fix that, then look for the actual cause of the poisoning. So the initial goal for an unstable, potentially intoxicated patient is to do, the quick ABCD approach, fix every issue that is in there, then go on and do, look for the cause by taking a sample history, as we're going to see. So the actual things that are supposed to be done in the ABCD are in the next presentation. So I'm just introducing it here. All right, so after stabilizing your patient, there are steps that you're going to need to go through. So, and it's the usual format that we usually do to approach any patient that presents to a hospital sick. So after doing the initial primary survey and fixing it, the next issue is to take a bit of history to try and ascertain, how the events happened and why they're presenting intoxified on whatever agent they're intoxified on. So that history could help you to try and dig out what the actual cause of the toxin, what the actual toxin they're exposed to is. Then the next thing to do is to do a quick examination, then investigations, and the actual treatment. So my talk is going to just focus on the history and the examination findings in these patients. So in history, what you're really going to be interested in is asking whether this patient was chronically taking any medicines. So because again, these could be the agents they're exposed to. Ask if there were any containers at the scene when the patient, where the patient was picked from, because those could be the agents they've been exposed to. Ask if there were history of conversions, because we know that most toxins do potentially have CNS effects. So it's important to ascertain whether they had a convulsive event prior to presentation to the clinic or to your hospital. And it's important to rule out any chronic medical illnesses that the patient could have, because that really has a big bearing on what treatment modalities you're going to institute. I could also give you a clue to that potential toxin that they could have. Because a patient who is, renally impaired, their renal function is not good. They could be taking drugs within the right doses, but because they're unable to excrete them, they rise to toxic levels in their blood, so that could cause them effects of those agents. So it's important to know whether they have normal systematic functions. So rule out any history of things like a renal disease. All right, so in examination, so this is just tells us what to look out for in examination. Do vital signs first, then do a general examination of this patient. Really, systemic examination is known as important when evaluating patients who are potentially exposed to a toxin, because there's nothing much that you're going to pick out from that. So in the initial evaluation of this patient, you're interested in seeing what their vital signs look like, and then doing a quick general examination to try and ascertain what derangements to their function they could have sustained because of exposure to the toxin. So when you do your examination, the first thing to do is to take their vital signs. So again, you're going to realize that they're going to have certain derangements in how their vital signs are looking like. So starting off with just the pulse alone of these patients who are exposed to toxins could tell us a lot about what toxins they could be exposed to. And you know that a pulse can range from between 60 to 100. So anything that's below that is slow, and anything that's above that is rapid. So evaluate these patients with the focus of knowing what pulse range they are in, because there's a list of different agents that could affect the cardiovascular function, and they're going to, derange how the pulse rate is going to look like. So these examples that I list down here, if you probably just put your attention to the bradycardia section, which is on the left, you see that there's a list of agents here that would slow down the heart rate if the patient is exposed to them. This is not meant to tell you that when a patient is bradycardic, then, they could have beta blocker toxicity, or they could be exposed to organophosphates. That patient who is bradycardic could really be exposed to anything, but this just helps us to narrow down to a list of things that this patient could have if they are bradycardic. But it doesn't mean that if they're bradycardic, then you're going to make a diagnosis of organophosphate poisoning. So those different agents that I've just bulleted down there, all agents that can cause a bradycardia in patients who could be organophosphate poisoned. Maybe just to put these things in full, the BB simply means beta blockers, and then the CCB is calcium channel blockers. We all know probably already that these agents all slow down the heart rate by blocking the AV node. So when a patient is exposed to them, their heart is going to run slowly because it's blocking electrical conduction within their hearts. So agents that could potentially cause a tachycardia, we know that any agent that's going to drive the sympathetic drive will potentially cause a tachycardia. So all those things that are going to block the parasympathetic effect, all the things that are going to stimulate the heart to run faster will potentially cause a tachycardia. So the other sign to look out for is the respiratory rate. Again, when these patients come to you, you're going to evaluate them from head to toe. So when you do the respiratory rate, it could be elevated or it could be slow. All agents that are acting centrally to depress the respiratory center in the brain are going to potentially cause a bradypnea. So those agents that are like opioids, benzodiazepines, other certain alcohols like ethanol, they're all going to act on the central nervous system to slow down the heart rate. So tachycardia could be still anything attacked centrally to increase the heart rate. So the other thing to examine is the patient's temperature. Certain agents could cause the patient's temperature to be slow, and others could cause the temperature to be high. So just a thing to pick out of this is that when a patient comes to you and you think they're exposed to a toxin, look for all these signs, correlate them to what that agent could be that they're exposed to. If they're hyperthermic, know that anything that drives the sympathetic nervous system, again, will have an effect on increasing the body's temperature. Drugs that acting centrally, like antipsychotics, are all going to cause these patients to have a high temperature. So examine these patients fully. Know that this is just meant to, give you a clue to what things they could be exposed to, but not necessarily diagnostic. So the other thing to look for is definitely the BP. All agents that slow down the heart rate are going to cause a reduction in the patient's BP. Again, it's important to note that any toxin that a patient is exposed to could cause the temperature, the blood pressure to be down. So when you see a patient with a low BP, just know that that's just a clinical sign that could happen in a patient who is exposed to a toxin, but not rather a diagnostic, finding in this patient. So it's just a clue to what particular toxins they could be exposed to. So when you're doing your initial evaluation, know that you have to take their BP just to help you, try and figure out what toxins they could be exposed to. So just a couple of slides ahead, maybe one or two. So when you eventually, so when you're done with taking their clinical, when you're done evaluating their vital signs, it's smart to, again, just go over your evaluation again, like do a full, complete head-to-toe examination to try and figure out certain things about, the clinical signs that they could have, because again, they could be predictors of what toxins they're exposed to, just on the previous slide. So on this slide, there's a very key examination that we want everyone who is exposed to a toxin to undergo. So just look into their eyes. They're really a big, a point of reference for what poison the patient could be exposed to. So some patients could have pupils dilated or constricted, depending on what toxin they're exposed to. We know that things like opioids, when they're taken in high amounts, they could slow down the heart. They could cause pupils to constrict. When someone is exposed to organophosphates, like the case that we just seen, pupils are going to constrict. So when you look into their pupils, look for their size, look for whether they have reactivity to light, because that could point to what toxins they're potentially exposed to. A key thing to note here is that some patients could get exposed to toxins, lose consciousness, and probably fall to the ground. So when they fall to the ground, they could sustain an intracranial bleed, right? So when that happens, some patients tend to bleed in their pontine areas. We know that pontine hemorrhage is one of the causes of pinpoint pupils, right? So when you examine their pupils and they're looking small, it could be, you probably need to do a CT for them, especially if the history is not very clear, not sure if they fell or not after ingesting the toxins, right? So when you examine their pupils and they're constricted, know that they could potentially be bleeding in their brain, and that could be confounding, the examination finding that you're getting. So it's important that you consider doing a CT for them. Certain agents cause pupils to be dilated. Again, these could be acronymized as the SHOW, and you could just look over them. SHOW could be, the S could be sympathomimetics, all things that cause CNS effects like hallucinations, anticholinergic agents, or a patient could be withdrawing from opioids. So this is definitely my last slide. Here, I just want to highlight to you that certain patients could be exposed to toxins and they present to you in sort of a paralyzed state when they can't move any of their limbs. So the things to consider when you think a patient is potentially exposed to a toxin and they present in a paralyzed state, is that they could be, they could be exposed to botulinum toxin and they could be in botulism, or they could probably be envenomized they were bitten by a snake that inoculated a toxin that paralyzed all their neurons and caused them to, present in a paralyzed state. Or certain patients that are exposed to toxins, and that's really in the late stages of the disease process, could be completely paralyzed. The other thing to rule out in patients who present completely unconscious and paralyzed is the possibility of a stroke. So you need to do a CT scan for them. All right. These are just my takeaway points. Treat every patient with potential toxin as any other medical emergency. The initial goal is not to look for the toxin to give them, but rather to resuscitate them and get them out of the immediate danger. And then try to look for what toxin they could be exposed to and for an antidote if it exists. A key thing to note here is that patients, very many toxins do not actually have antidotes. So that means that the initial management that you're going to, run for these patients is going to be to offer them that initial stabilization and try to get them out of danger, and really all the supportive care that they're going to need to stay alive and get out of the intoxication. All right, that's it about my talk. Thank you for listening. Probably the order is that we take questions now or at the end of the session. So you can feel free to ask any questions if there is, or any supplements to my discussion. All right, I'll hand you back over to the moderator.
Thank you so much, Dr. Kamoga, for the well-detailed presentation. Keep your questions, supplements, and any reactions coming through the chat. So at this point, allow me invite our senior mentor, Dr. Harry Chen, who will be taking us through the clinical investigation and management of an acutely poisoned patient. Thank you. Dr. Harry Chen, you're most welcome.
Thank you. Can you hear me okay? Can you hear me okay? Great. I just want to say hello to everybody. I'm delighted to be here. I probably shut my video off because of the bandwidth issue. So good afternoon, everybody. I'm grateful for the case presented by Dr. David. Indeed, it was a challenging case, and you all heard that Dr. Dixon outlined the common poisons here in Uganda and really highlighted some of the global burden of disease that we see, especially in low and middle income, low resource settings. I think we have to understand, and I hope that Dr. Dixon really emphasized that this is really, it's kind of detective work we have to do to both identify what it is that a person may have taken, much less they take a poison, and to really identify the specific toxins. So in my talk today, I'm going to speak about the role of diagnostic testing, which is limited in the treatment of the poisoned patient. I'm going to talk about the steps in management and hopefully highlight some of the very specific strategies we can use, such as antidotes, decontamination, enhanced elimination, and rarely something like dialysis to address our poisoned patients. But first and foremost, I want to stress that that the care of the poisoned patient is really what we do every day. It's supportive treatment, and it's identifying the A, B, C, D, E's and dealing with them as you find them. And it's only in very, very specific instances that you may turn to some of the strategies we talk about. And finally, I'm going to spend a couple minutes really commenting on the case that Dr. David presented. So turning to the diagnostic testing, I would really highlight that the role of diagnostic testing is limited in the poisoned patient. And I think that as limited as it is in high resource settings, it's even more limited in low resource settings. So the detective work that you do will ultimately be based on your physical exam, a really good history, and trying to categorize your patients into some of these toxidromes, which I'll talk about later. But a toxidrome is really a clinical fingerprint of a poisoning that will guide you into what it is that a person ingested. I think the diagnostic testing plays a secondary role. And importantly, I'm going to run through a few of them. So routine, I think we all do it. And I love the way you do it so well here in Uganda, which is the RBS, because you don't want to ever forget the glucose, because it could obviously have serious impact on your patients. There are certainly drugs and ingestions that will lead to hypoglycemia. And you could truly make a difference if you test it early on and aggressively, because you can get that lab right back right away. Finally, I'm going to just make a pitch for urine pregnancy a test as a routine test in emergency medicine, because, I mean, truthfully, I want to know if I'm treating 2 patients. And I think you want to know if you're treating more than 1 patient. So importantly, I think it's a reasonable thing to assume. ECG, we saw an ECG in the case that Dr. David presented. And I think that it's not always available, but it can really help you in the diagnosis of certain ingestions. So for example, I'll show it in a bit. Tricyclic antidepressants have a characteristic ECG, a picture. Beta blockers, looking at the rate, looking at the intervals, looking at the conduction disorders can help you identify certain toxicities. X-rays, radiographs are generally not helpful, but you can go back. We're still on the one more. We're back one more. Just back, yeah. Okay, so let me finish this slide. So generally not helpful. There are really 2 instances that can be helpful, interestingly enough. One I'll show you shortly after I run through this, which are pills that show up in the GI tract. Primarily, one of the major ones is iron. Some of the long-acting beta blockers and or calcium channel blockers can also show up. And then there's something which you probably don't see much here, I think, thankfully, which are body packers. These are individuals that ingest packets of illegal drugs and transport them in their GI tract. But those also show up generally on X-rays. Electrolytes, as were obtained in this particular case, can really help you guide you also in terms of what toxin is available. And I would make a plea to getting a bicarb to calculate the anion gap, because there are certain toxins, notably the toxic alcohols and salicylate, that will be hidden unless you look at that anion gap, but not always available to us, and I understand. Renal function and hepatic function. We know that the kidney and the liver are the 2 of the foremost organs that both detoxify toxins in the body, but also they concentrate those toxins. So some of the kind of unspecified differentiated toxins will have effects on both the kidney function and the liver function. And getting those baseline tests will help you identify that down the road. We'd love to say that you could check a urine or check a blood test, and it'll tell you what the actual poison is. But they're really impractical. They're impractical in a high resource setting, and they're actually and they're even more impractical in the setting such as you all practice. And then finally, I'm going to make a pitch again. Also, if possible, if you could have it available for blood gases to help you with acid-base status and a measured serum osmolality again for some of those toxins, which would be wonderful to know because there's something you could possibly do for them. Okay, the next slide. So here's an example. I mean, this is an X-ray of a patient who ingested iron, and you can see a woman who ingested iron, and you can see the iron pills in her stomach. Obviously, iron can be significantly toxic, much more so for pediatric patients rather than adults. But this is a patient who you may, I'll discuss in a little bit, you may decide you want to increase the transit of these pills through the GI tract with something we call whole bowel irrigation. The next slide. So I think I want to just kind of stress one thing to everybody is that the underlying approach to the poison patient is supportive. And because of that, your priority obviously are the ABCs, but in addition, your priority is staff and actually patient safety. I think the literature is replete with stories of individuals who work in hospitals taking care of people who became ill because they were taking care of a contaminated patient. And organophosphates is really one of the classic examples of that. And that is because organophosphates are highly lipid soluble. And in addition, they can be absorbed through the skin. So things like organophosphates can be absorbed through the skin. So removing clothing really right off the bat, putting on your PPE will both help the patient and help you. If you are going to clean externally, then using soap and water is ideal. Sometimes just water is adequate for kind of caustic chemicals, so to speak. I think of note that one of the common exposures we see, which is obviously not life-threatening, but certainly threatening in its own way, is a toxic exposure to the eye. And rapid irrigation is important, ideally with saline, but you can use just water. To dilution, so the old saying that the solution to pollution is dilution is really pertinent here. Getting those vital signs is important, and I want to just stress, based on Dr. Dixon's presentation, the temperature. We don't always take the temperature, but in the poison patient, the temperature can be highly useful in terms of identifying certain toxidromes, i.e. sympathomimetic toxidromes like amphetamines or things like cocaine, but also for hypothermia related to sedative hypnotic drugs. Oxygen saturation in RBS, as we mentioned previously, is important to do to identify interventions that you need to take. So let's start with the airway. Go back to the airway, obviously, it's important to identify what are the reversible causes. So for instance, if there is an airway obstruction related to hypoglycemia or opioids, that's something you can actually reverse fairly quickly with either glucose, and if you have naloxone available, with naloxone. Clearly, what the most common cause of airway obstruction is lowered level of consciousness, and that may require airway protection with interventions like a Goodell airway or nasopharyngeal airway. I think I want to caution people to be aware historically of a caustic ingestion or thermal injury. I mean, one of the ones that Dr. Dixon mentioned was bleach, which can, or other lye, which can cause damage to the airway that may not be immediately apparent, but may be rapidly progressive. And it would be important to identify those individuals because you want to intervene with an airway sooner rather than later, because the law. Next slide. If we could have the next slide, please. So breathing, which was on the next slide, please. Obviously, we mentioned the opioid and the sedative toxidromes. We know that respiratory failure, there really classically are two forms of it. One is hypoxic, related to a ventilation perfusion mismatch, or hypoventilation. And you could see both. Back up one slide, please. You could see both with overdoses. Classically, an opioid exposure relates to hypoventilation, and some of the sedative hypnotics versus an irritant, which leads to a hypoxic respiratory failure related to a ventilation perfusion mismatch, an impairment of the capillary alveolar capillary membrane. Cholinergic toxidrome, which was this case in this particular case, I just would caution you that if you are going to use, if you are going to do an intubation, to use succinylcholine with caution, because obviously that's our go-to drug for paralysis prior to intubation. But in a organophosphate exposure, the enzyme that breaks down succinylcholine is the same enzyme that's affected by the organophosphates. So ideally, you use a non-depolarizing agent like pancuronium or rocuronium, but I understand that may not be possible. So if you end up using succinylcholine, make sure that you're sedating your patient for the duration of their paralysis. Airway adjuncts, we all know that things like diaphragm masks, oral airways, and nasopharyngeal airways are really key to maintaining that airway. LMAs should be something we do if we can't do intubation. And then obviously the kind of gold standard of airways is a orotracheal intubation. But take advantage of all the other adjuncts that you have available. Circulation. I think we mentioned the QRS duration of the ECG, looking for heart blocks that you may see with both beta blockers and calcium channel blockers, looking for some of the intervals that are prolonged with things like phenothiazines, and then looking for dysrhythmia, because all of those things may help you in terms of that detective work that you have to do to identify the toxin, but also to guide your therapy. Hypotension, I think it's fairly straightforward, just like you do every day, which is isotonic fluid bolus, either normal saline or lactated ringers, and then trying to pick a direct-acting vasopressor. The two that are commonly used are adrenaline and or adrenaline. And then I want to make a pitch for taking that temperature, which is not always highest on your priority, but also actively cooling, because we know that for instance, the sympathetic toxidrome, which like amphetamines or cocaine, that it's that hyperthermia, also salicylates, that actually causes the end organ damage, and rapidly cooling them can be organ saving in terms of function, but also life saving for those individual patients. Next slide, please. So, it's always, we talk about antidotes, and it would be wonderful to have an antidote for every exposure. And there are extensive lists of antidotes. I've presented a relatively short one, primarily because I could give you a list from A to Z, and you might be able to only acquire a handful of them. So I think it's just important to understand that antidotes are great if you have one, but you may not be able to get it, and you're still going to have to rely on your supportive therapy. So just as an example, in this particular case, atropine and pralidoxine, which I'll talk more about later, those are the antidotes for organophosphate poisoning or a cholinergic toxidrome. Calcium Both calcium and glucagon are usually antidotes that you may have available, probably calcium, sometimes glucagon, for beta blocker ingestions and also calcium channel blocker ingestions. Physostigmine can be used to reverse anticholinergic poisonings. Most people don't use it a great deal because most of those poisonings can be managed totally supportively. Vitamin K, we know that many of the rat poisons contain warfarin-like drugs and superwarfarins, and so vitamin K is truly an antidote for that to prevent the severe coagulopathy that may occur with that. Naloxone, as I mentioned, is a antidote for opioids. I'd say that we use a lot of it in the U.S., but the reality is if you don't have it available, what you have to do really is just support the respiration. So an opioid overdose, what the naloxone does is block the opioid receptors and allow them to breathe again. But if you breathe for them, that supportive treatment is really essential for them for their survival. Antivenom, snake bite venomation is certainly not uncommon in Uganda, and knowing where it is, how it's available, and when to use it is important. Bicarbonate is an antidote for tricyclic antidepressants, which is one of the more common kind of lethal overdose in the U.S. Dextrose for certain agents that lower your blood sugar, i.e. sulfonylureas and insulin. And then ethanol, interestingly enough, is considered an antidote. And it's an antidote because it competitively inhibits conversion of the toxic alcohols, methanol and ethylene glycol, to the toxic metabolites. And it's really methanol and ethylene glycol by themselves are not toxic, but they create toxic metabolites that have CNS effects that crystallize in the kidney and lead to renal failure, blindness, severe acidosis, and death. Next slide, please. So here's an example just for of a tricyclic overdose. You can see the ECG up on the left is showing a Y complex tachycardia. The QRS is wide, the heart rate is fast, and then you give this patient bicarbonate, and that's the same patient after a dose of bicarbonate. And you can see that now the ECG has normalized significantly. The QRS complex is narrower, and this patient's at the same time, their blood pressure will follow the same pattern, meaning they may be hypotensive when their ECG is on the left, but they may have a better blood pressure when their ECG has normalized. Next slide. Once you identify the poison, we need to assess, is it amenable to some of our other strategies? And the two strategies are really decontamination, not the external as we talked about, because we've already, I think, underscored that as an important strategy, but also a decontamination of the gastrointestinal tract. For example, this is where we talk about charcoal and gastric lavage. So gastric lavage used to be fairly common with ingestions, but really it's no longer recommended. And the reason why is because A, there was very little benefit, and B, there were certain patients that had an untoward event related to that, usually aspiration or putting in the lavage in the wrong aspiration. So I would not even bother with that now in terms of gastric lavage. We talked about, in this case, activated charcoal. And I think charcoal is great. Really what activated charcoal is it's has a kind of a multiplied surface area and will absorb probably most chemicals. And so if you can give it within 1 to 2 hours and know that there's a secure airway, I think it's reasonable. But I think having spent enough time in Uganda, I don't think you see anything within 1 to 2 hours. So I think that I think it's really understanding that and really trying to counteract your urge to do something when doing something may won't work and B may harm the patient. So in terms of activated charcoal, there are it really will absorb almost everything. The things it won't absorb are things like metals. So metals, they won't absorb alcohol, different alcohol, including methanol, it will not absorb. And there's probably a contradiction, it won't absorb corrosives. But almost everything else will be absorbed by activated charcoal. So it's really a good drug in that respect if it's given within that time frame and if it's given to a patient with a secure airway. Now, there are classically, when we talk about charcoal, we talk about single dose activated charcoal, but there are certain ingestion where giving multiple doses of charcoal can actually help. And it really takes advantage of the kind of enteric absorption to reduce the drug that's within the system and absorb most for some of the drugs through the system. And some examples of that are carbamazepine, phenobarbital, salicylates, and aminophylline. Those are some of the drugs that occasionally it's useful to do multi-dose charcoal, which is repeat doses, maybe every 4 to 6 hours for a day or two. I did mention whole bowel irrigation. So, that patient with the iron in their GI tract, the iron pills, could be useful sustained release tablets, and the ones that we often see are the calcium channel blockers, and then the individuals that are carrying packets of drug within the GI tract. And whole bowel irrigation is very similar to the prep you get if you're going to get a barium study or a colonoscopy. It basically just moves everything through your GI tract quickly. It's not a cathartic per se, but it does use kind of osmotic forces to keep fluid through the GI tract to move those things through quickly. Finally, hemodialysis. I think it'd be important for you to understand where can you get dialysis nearby in your medical system. And the chemicals that I think are really can be life-saving for hemodialysis include methanol, ethylene glycol, and salicylates because of their severe acidosis. Again, that conversion of the methanol and the ethylene glycol to a toxic metabolite that ultimately provides the end organ damage, leading to potentially the death of your patients. So knowing where a dialysis center is available. So here, this is an example. What's the problem with giving activated charcoal? Well, this is activated charcoal in a patient's lungs that obviously did not do well. And so we want to be certain that if you are going to give it, that it's indicated, meaning time frame, that it's safe, and that NG tube that you put in is in the right place, and that the patient has adequate protection for their airway. I mean, I think the principle of do no harm really is important for us in medicine. to best take care of our patients. Next slide. So here are the toxidromes, and I just want to stress that this presentation today is the first of several, I think, that will really highlight some of the important poisonings that you may be confronted with. But the toxidromes are really this chemical fingerprint. It's a chemical fingerprint that allows you to look at a patient with a good physical exam, vital signs, to be able to determine, what is it that they took, and then importantly, what is it that you can intervene with in terms of improving their clinical status. So I think we talked about the anticholinergic toxidrome, the classic ones. It's like too much atropine, or it's the some of the plants that are anti-muscarinic, and also antihistamine, like diphenhydramine and some of the phenothiazines. So the anticholinergic toxidrome is characterized by mydriasis, tachycardia, flush skin, dry skin, in mucous membranes, urinary retention, decreased bowel sounds, delirium, and hypothermia. So there's a phrase that is somebody who is anticholinergic is blind as a bat, red as a beet, mad as a hatter, dry as a bone, and hot as a hare. So you think of that, you've got, think of the Mad Hatter and some of the children's stories. That's the anticholinergic, anti-muscarinic toxidrome. The next one is the cholinergic toxidrome, and that's what we saw today, which is in the case that presented by Dr. David. It's organophosphate compounds and carbamates, and it's sludge. I mean, there's dumbbells. I tend to use sludge. You could use whatever you want, but it's salivation, lacrimation, urination, diarrhea, emesis, and gastrointestinal upset. So meiosis, bradycardia, bronchorrhea, bronchoconstriction, nausea, vomiting, diarrhea, lacrimation, and urination. So you should be able to walk into a room, see a patient who has all of those things, and say, without any hesitation, this is a cholinergic toxidrome, and I need to treat it as such. Opioids are another one that's common, and that's individual with respiratory depression, meiosis, tiny pinpoint pupils, lethargy, coma, and decreased bowel sounds. A sympathomimetic toxidrome, like with the methamphetamine, cocaine, and some of the decongestants like pseudoephedrine, mydriasis, dilated pupils, tachycardia, hypertension, diaphoresis, agitation, and hypothermia. Again, it's your sympathetic nervous system. The sedative hypnotic toxidrome includes, diazepam, benzodiazepines, barbiturates, and alcohol. This lethargy, coma, hypothermia, as opposed to the sympathomimetics, which have hyperthermia. Respiratory depression can happen, but it's most often with mixed ingestions, especially alcohol, but still can occur with any sedative hypnotic. Next slide. So once you identify that, so you see that walk into the room, you see that cholinergic patient, you say, boom, that's probably organophosphate phosphates, and to treat a cholinergic toxidrome, I need atropine, potentially pralidoxine, and I'll talk more about that shortly. Diazepam for their seizures, because that's what is causing that toxidrome. Finally, again, sympathomimetic toxidrome with the tachycardia and the agitation and the hypothermia. You want to treat them with diazepam first, but if that doesn't help with their blood pressure and their temperature, then you can move to antihypertensives. If you decide you need to treat an anticholinergic toxidrome, you can use physostigmine. The opioids, as I already mentioned, naloxone, or you can definitely get away with purely supportive management. And then sedatives. It's really about your ABCs and how to address that. We'll take care of it. Now, disposition, I think it's important that understanding that you're seeing these individuals in your emergency ward, and you have to decide what you're going to move further along with their medical care. And obviously, ICU is where this patient, Alago, was headed. It could be a medical ward. It could be a psychiatric ward. And I think, or it could even be home after a psychiatric evaluation. I think that's important as a part of your history to understand, was this intentional? Was it, and how, what's the underlying kind of motivation for this ingestion? I think also important to understand, is this patient in a state that you could actually assess them for that? I.e., are they with it enough for you to do an evaluation of them psychiatrically and or in terms of their capacity to say yes or no? And then finally, I think it's most of these are intentional self-ingestions, but there are unusual times where somebody may be poisoned. So is this poisoning a crime? Do you need to talk to police? And then finally, just like you would report an epidemic, a case of Ebola, you need to report if there's something that you think is a public health threat. And the thing that comes to mind really is, say, homebrew. Somebody's making homebrew and they're cutting it with methanol. And we certainly, at least historically, have had episodes of that here in Uganda. And that methanol poisoning, so if you see more than one patient, you need to consider, is this something that was malicious? And is it a threat to the public's health? Next. So here, in a study in the US, are the predictors of a complicated course and people who probably need to be in the ICU, ventilatory status, need for intubation and airway, seizures, unresponsiveness, hypotension, and ECG changes. None of this is common sense. And obviously it depends on A, do you have an ICU? B, do you have an ICU bed available? And what are the resources you have that you'll be able to deal with that? So I think there's many different possibilities. So the next slide. So I want to just briefly touch on the case that was presented by Dr. David. And I think one of the things, my understanding of the case that I think is important for our discussion is that it was probably 8 hours between when the patient ingested the striker and when they presented to the hospital. So that's a lot of time for that organophosphate to work and do its damage. So I want to adequate external decontamination, especially for liquid soluble chemicals such as organophosphates, because their clothes will continue to expose them to organophosphates, poisoning, and anybody taking care of that patient will potentially be poisoned by the clothes of the patient itself. So remove the clothes, soap and water. Some places say twice or 3 times. Charcoal, again, remember, it's not indicated after 2 hours because of the limited effectiveness, potential harm. I think atropine, I think that there's a lot of different regimens, but I think really what it comes down to is you have to give a lot of atropine. So if you want to start with 2 milligrams, give 2. In 5 minutes, if they're still having what secretion should go for. So it's really doubling it every 5 minutes. And as you could see, you end up with a lot of atropine. But I would stress, don't be bashful with the atropine, because that will save their life. You want to give them atropine at doubling doses at that 5-minute interval until their heart rate's greater than 50, 80, that their lungs are dry. That's really the bottom line. And the secretions are dried up, and that their blood pressure is greater than 80. There's been some reports in the literature about using adrenaline to kind of supplement the heart rate, getting the heart rate up. There's also some reports about using magnesium too. Again, not evidence-based, but certainly I think if a patient it is sick enough worth considering. And then importantly, that once you atropinize a patient, you have to give them a maintenance drug, which is 10 to 20% of the total dose per hour. So you know, if you're using that, whatever you use, take 10% of that or 15% of that, and then put it in a drip and run it that dose per hour. If it's not enough, you can always rebolus them with atropine and increase the drip, just like any other drip you're titrating. If it's too much, you can hold the drip and then restart it. I think the evidence is that diazepam is the preferred agent for seizures, primarily because of the mechanism of action, which is through the glutamine stimulation excitation system, a system of which diazepam and all benzodiazepines is an antagonist. I think that pralidoxine, there's some controversy about pralidoxine. It's kind of routinely given in the US, but I think that the actual data is not as clear as probably we would all like in terms of using pralidoxine. Pharmacies, it might be worth looking into your environs and what the pharmacies have available. So in summary, I think that the key comments of this case is very in more aggressive atropinization with a maintenance infusion, pushing the diazepam up to for the seizures, and consideration of the use of pralidoxine would really be aligned, better aligned with kind of expert advice and best practice. Next slide. So with that, I want to thank you for your time and attention. Again, I hope that this is a good introduction to poisoning in general that will be carried on with further cases in the ECHO. Thank you.
Thank you, Dr. Harry, for the great presentation on the management of an acute poison patient. Keep your reactions and questions coming through in our chat, as we shall handle them after the next presenter. At this time, I warmly welcome our last presenter, Ms. Alice Kabasoga, who will be taking us through the nursing care of an acutely poisoned patient. Thank you.
Thank you so much on my previous presenter. Thank you so much, Dr. Chen. You made my work actually so easy because you actually almost talked about everything I'm supposed to talk about. Put on the slides. So we are going to dive in the general nursing care of a patient with acute poison. The slide. Yeah, we are going to look at the general nursing care of the patient with acute poisoning, where in our nursing care, still a nurse has to do a general assessment of the patient. You have to identify the poison and look at the intentions, why the person actually took the poison and its effect. In the assessment, you have to obtain the detailed history of type of poison ingested, amount and time of the injections, or any known allergies or current symptoms. That will direct your care of plan as you're planning to care for this patient with poisoning. In the intentions, you look at whether it was accidental, as commonly seen in children, in elderly, or accidental overdose. You have to establish whether it was suicidal, seen in psychiatric patients, in long critically ill patients, emotionally unstable people. Sometimes it will be like a criminal act where somebody is actually poisoned at workplace. It occurs more often, like a case of rape and robbery, where somebody sedates you fast. Yeah. Sorry for the interruption. Also in assessment, we'll have to look at the general survey. That one has already been talked about by my previous presenters, where you look at the signs and symptoms, you look at the medication, the past medical history, where the patient has the history of being a psychiatric case, a social history, where most time people having hard times, people can't handle stresses of life. The last meal taken, an event leading to ingestion of poison, or the preceding events. And also, the nurse have to obtain their sample for electrolytes. They already talked about that. It is very important actually for us to do electrolyte, find out electrolytes of these patients. We obtain samples for RBS, that is random blood sugars. We do an ECG. You have already seen Dr. Chen projected the effect of toxins on the heart muscles. Then we also have to do a urinalysis. In urinalysis, we just want to know in an event that the toxin is being excreted by the kidney, most likely you're going to get the toxin in the urine. We need also to find out about the liver functional test. If there's some toxicity in the liver, the renal functional test, so that we ascertain the early onsets of AKI. We also need to do an ABGs in these patients, that is arterial blood gas. We want to know whether the patient has metabolic acidosis or the patient has alkalosis somewhere. So we do also a baseline, obtain sample for a baseline CBC. We just want to know if there's some inflammatory processes going on in there. CBC will have to tell us. So there are some few possible nursing diagnoses in these patients, where we say this patient most time have acute pain. Sometimes when they present with diarrhea and vomiting, they are going to get fluid volume deficit. Sometimes when they present with the airway problems, they are going to have an infective breathing pattern. They're also going to have an infective airway clearing for those who have secretion in the airway, or blockage due to maybe edema of the airway. They also have infective coping for those ones who have suicidal attempt, like hopelessness, low self-esteem. That refers to people who have suicidal attempts. Social isolation also, or impaired mood regulations in patients with psychiatric, baseline psychiatric cases. Next slide. So in planning, we are going to set goals and expected outcomes. In short-term goals, we want to stabilize the vital signs while offering supportive care to these patients. We want to decontaminate internally and externally. Dr. Chen talked about that. And we want to administer antidote to these patients to mitigate the effect of poison. And we want to enhance elimination of this toxic substance from the body. In the long-term goals, we want to educate these patients for those ones who had accidental poisoning, and for those ones who have psychiatric cases. We want to involve family members or significant others and to also involve psychosocial team for counseling. Next slide. So a goal 1, to stabilize the vital signs, you ensure that actually there is pattern airway, you inspect and dislodge any blockage in the airway, you clear secretion. This is just to prevent aspiration of toxic content, which may further compromise gaseous exchange. Remember, they already come, most of them come in already struggle with respiration. So in an event that the airway is not patterned, even if you administer oxygen, still you are not going to achieve anything much there. For unstable patients with low GCS, should be immediately evacuated for high-level care in ICU, mechanically ventilate to comprehensively monitor the patients and protect the airway and support respiration and provide time to correct insults. You realize that mechanical ventilation is not a treatment, but it provides us time to correct the insults. These are the insults caused by the ingestions of the toxic substances. And we are going to give oxygen. We're using high flow devices and keep oximetry above 95, especially in carbon monoxide poisoning, where I said you give 100% oxygen. This is to support the cellular respiration and to compete for binding site favorably. Remember, carbon monoxide like competing for binding sites with the oxygen. So for oxygen to compete for binding sites, you have to administer at least 100%. We also administer fluid, preferably crystalline solution. There are several other formulas which are used to calculate fluid for replacement. This is to prevent circulatory collapse and to dilute poison and promote elimination. Most time in normal setting, we use normal saline, we use Ringer's lactate, but we need to calculate the doses appropriately so that we prevent fluid overload. And also you have to put a fluid balance chart. You monitor the intake of these patients versus the urine output. In that case, you'll be able to establish if there's an incoming AKI setting in, so that you mitigate the effect of AKI in time. You closely monitored oxygen saturations, vital signs, and cardiac rhythms. Remember, when we looked at what Dr. Chen projected, the effect of the poison on the cardiac muscles, the patient is most likely going to have cardiac arrhythmias. So that will help you ascertain early onsets of multi-organ dysfunctions. You also have to feed these patients. I've not had anybody feed this patient, but most time before you feed, you need to establish that they actually boil sound. You do gastric aspiration to see if there's gastric emptying. In an event that is actually gastric emptying, you give the patient small frequent feeds, 2 hourly, but give plenty of oral fluid, avoid spicy food or acidic food, because you can never know if the poison has caused gastritis. You carry out, for unconscious patients, you carry out a general nursing care for these patients. You do an oral care, you give the bed bath, you change position, you manage pressure points, you protect the eye, you care for the catheter, you do partial exercise. All that is done just like general nursing care for unconscious patients. In handling our objective 2, goals number 2, we have decontamination, where we say we have to do decontamination internally and externally. External, we just perform a bed bath and we do high irrigations. You use plenty of water and soap on the skin, but in the eye, you just use plain water to as a decontaminant agent. In burn patients, you also follow the established burn management measures. These are just to minimize the effect of dermal exposure, prevent reabsorptions, and the tissue destruction of tissues, and accidental secondary poisoning on health workers and caretakers. It is very possible you can easily get poison yourself when taking care of the patients. If you don't bathe these patients, remove the clothing, bathe and change, you are most likely going to poison yourself from a secondary source. And GIT reabsorption elimination, the decisions, that one is individualized because not every patient, like in petroleum poisoning or other sorts of poison, not everybody go through the same process. Gastric lavage, Dr. Chen has already told you that it is not indicated. However, I also wrote that it is highly controversial because of its potential complications like hypoxia, gastric perforations, aspiration pneumonitis. However, if you do it, probably you are going to do it just to wash out and should be done within the first hour of ingestions of what? Of poisoning. Probably just to stop the reabsorption from continuing. However, it is contraindicated in petroleum products, acidic substances, and in the patients who are not able to protect their airway. Next slide. Decontamination still, we can do whole boil irrigations with glycerin substances through either nasogastric tube, which is, you do it like 25 mils per kg or 40 mils. You just pass an NG tube, then you pass that substance to clear the system up to the rectum. This is just to remove the toxin substance from rectal tract as fast as possible. But it is only common in lithium ion poisoning and that opioid packet poisoning and heroin and cocaine, contraindicated in a gastrointestinal bleeding or mechanical or functional bowel obstruction. And for those patients who are unstable, who cannot protect their airway. Next slide. Next, okay. There are some goal number 3, that is to administer the antidote. There are some few antidotes. If you look at them, they are there. Though Dr. Chen also hinted on that, but you can go through that. I'm not going to go through all of them. Next slide. The fourth goal is to enhance eliminations. So you have to prepare the patient for extracorporeal methods like peritoneal dialysis, hemodialysis, or hemoperfusion for those poisoning resulting into toxic metabolic activation, severe metabolic acidosis, and those refractory to supportive treatment modalities. When you have given all the treatment modalities and actually the patient is not responding, so the next thing is actually to eliminate the poison from their system. So most time they do peritoneal dialysis, you can do hemodialysis, you can do hemoperfusion of these patients to eliminate the toxins from their circulations, which can potentially be toxic to the vital organs. Then post-absorption elimination, you just administer multi-dose activated charcoal, which still they said it is controversial because they said at what point do you administer charcoal, and the effectiveness of charcoal after 1 hour of injections. Anyway, this one they said is to disrupt the enterohepatic circulations by binding different substance, making it inaccessible for absorption in the GIT, and to eliminate toxic substance that undergo enteric or enterohepatic circulations. But they said it's only effective within the first hour of injections. Of course, that is also contraindicated in people who have airway, their airway is compromised, reduced consciences. Until you intubate the patients, then the patient will be able to go through the treatment. Next slide. So on our long-term goal, we talked about educating patients. You help educate patients, so a danger of exposure to toxic substance, need for self-care and PPEs. When you know you're handling patients who have had poisoning, please protect yourself adequately. Otherwise, you're going to get secondary poison from this source of poisoning. Involve family members and significant others to monitor change in behavior of these patients, when to return to the hospital. Counseling comes in there, involve the psychosocial team, where you link for rehabilitation for those ones who are medically broken down. For psychiatric patients, you link them for treatment. For those ones who are depressed, you can also link them to psychiatry. For those who have social problem, you can link them to psychosocial team for counseling. Next. So we have to evaluate our patient. We reassess and plan. We want to determine whether their goals have been met. We want to see the effectiveness of implemented intervention in achieving our desired outcomes, like stable vital signs, hemodynamic stability, reduction in symptoms. We want to recheck the vital parameters to reassess the level of consciousness and adjust a clear plan. We have to modify based on patient responses, ongoing assessment, and new emerging needs. We have to document all and maintain detailed records of these patients, assessment interventions, and patient responses. And of course, we shall not forget to hand over this patient to the next shift at the end of the shift. And most time we use SBAR for handover. That is the situation, the background. Then you do assessment and recommendations. Then you hand over that patient to the next shift. Next slide. Oh, we come to the end of the presentation. Thank you so much for listening.
Yeah. Thank you so much, Sister Kawasoga, for that wonderful nursing care presentation. It was indeed wonderful. That's what we call a mentor and a senior. So at this point, there were concerns, reactions, and a number of questions that were repeatedly raised in our chat. And I would kindly request our panelists to attend to them. So, and the above and the following are the questions. So in the chat, so many people raised, what was the indication for the use of atropine? What was the dosage and the frequency of administration? And when do we achieve atropinization? The second question was, what was the management plan for a pregnant woman acutely poisoned? And the third question, what was the indication for salbutamol nebulization in our patient? And the other question was, after how long was the patient taken to hospital from the time of ingestion of the agent? And lastly, why wasn't pyridoxine given to this patient? Meanwhile, I would also invite Dr. Sarah to echo out the questions raised through the chat in case she has some of them. Thank you so much. I warmly welcome the panelists to attend to some of the questions raised. Okay, thank you.
Okay. Thank you, colleagues, for those wonderful questions. I think I'm just going to take on question 3 and question 5. How long did the patient take to get to the hospital? And why did we give salbutamol? From the collateral history we got from the relatives, this patient took the poison in the morning and they are from Mitiana, but they go to the hospital around 1. So probably it took them around 6 hours to get to the hospital, and that's quite long. The reason as to why we gave salbutamol is from Dr. Harry's presentation. If you look back at the toxidrome of cholinergics, when you look at the sludge, we always add there the killer bees. The killer bees are bradycardia, bronchoconstriction, and bronchoria. Yeah, so much as you're giving atropine to dry out the secretions, you will also have to deal with bronchoconstriction. And in that case, you use a bronchodilator, which is salbutamol, to make sure at least those secretions that are there, much as they are drying out, you are able to get them out with a dilated airway. Thank you.
Thank you so much, Dr. David. So I warmly welcome Dr. Kamoga. Take on other questions.
All right. Thank you to whoever asked these questions. They're really great questions. If I probably assume that these questions were asked before Dr. Harry's presentation, because he kind of tackled almost everything about why atropine is given, what doses, and what frequency. I don't know if I should actually just go through them again, but yeah, they were actually spoken about. So whoever asked them should have gotten the answers really during Dr. Harry's presentation. Maybe just about pregnancy, the treatment is the same, it doesn't change. It's one of those situations where you're going to just treat the patient because they are acutely poisoned, and you're going to do it the right way. I mean, the same way you do it for a patient who is non-pregnant. So all the treatment modalities stay the same, even in pregnant women. So yeah, atropine is still applicable in these patients, irrespective of the gestation age the woman is at. So just go on and give them atropine, same doses, escalating doses, and until the patient is atropinized. Yeah, that should be it. Okay, I'll get back to the moderator.
Okay, thank you so much, Doctor. Dr. Sarah, do you have any reactions? Kindly unmute and talk to us.
Thank you so much. I have handled most of the questions in the chat room and in the Q&A window. However, the other questions that I had wanted to give the panelists to answer, Dr. Kamoga has answered them. And I think I don't have much to share with you. Thank you.
Thank you so much. Thank you so much, Dr. Sao. As we are heading towards the end of today's session, I thank each and everyone that joined and listened to today's session. I also thank our panelists for the great work, the wonderful presentations, and knowledge they have shared today. Thank you for the great insights. On your screens, the post test has been posted. Kindly fill it in as I welcome my fellow panelists to give their final remarks about today's session. Thank you so much. You're welcome, Doctor.
Thank you very much, colleagues. Once again, I'm Dr. David Mirumubi, and it has been a wonderful session. I want to thank you all for being active participants, and thank you for having the spirit of learning, and let's all continue carrying out the best practices. Thank you.
Thank you, Dr. David. At this point, let me invite Dr. Dixon to give us his remarks.
It was great having all of you on this session. I think there was, we hit 500. That was really a remarkable number. So I think it was really an exciting session. There's a lot of issues that were, spoken about here and there. I believe everyone who's joined in today has had a few things to walk away with. The key thing that I really want to highlight from my talk, again, I spoke about it towards the end of it, is that all patients that are poisoned should be, initially handled as any other medical emergency that could present to your clinical setting. So there's always a tendency of, trying to find out what toxin it is, whether there's an antidote, and you're focused on trying to figure out what thing they've been exposed to and whether there's an antidote that you're going to give them. But really what matters in managing these patients is, taking them out of the initial danger, treating things that are going to cause them death immediately, as opposed to looking for what toxin it is and what antidote you're going to give them. So the initial goal of care stays the same for any medical emergency. Just go on and fix the ABCDs, then look for the antidote if it's there, look for what has caused the poisoning. Majority of these patients actually do well with just supportive care, IV fluids, give them oxygen, monitor them. That's usually adequate enough to take them out of the poisoning that they've actually ingested. All right, that should be it from me. Once again, I'd like to thank you all for having us for this session. All right.
Over to me, okay. Yes, I want to thank everybody, my fellow panelists. I don't know, to my fellow nurses, let's handle all acute poison as critically ill patients. Whether you think the condition is mild or not, just handle it, because you can never know the effect of poison on the vital organs. And let us take our documentation very seriously, because most time we lack in documentations. We have to step up our documentations about all what we do on these patients. And finally, I want to thank everybody who logged in, because this is a cross-cutting event. It happens everywhere, and it happens in all ages. Thank you so much, and be blessed.
Thank you so much. Allow me to invite Dr. Harry Chen for his conclusive remarks about today's session. You're welcome, Dr. Harry.
Thank you, and thank you to my fellow panelists for their very informative presentations, and to our moderator who ably handled the conversation. I think that the real heroes here are all the hundreds of people who are listening in because of your desire to learn more and better yourself. I just would really emphasize what Dr. Dixon said. The treatment of poisonings is really what you do every day in terms of the A, B, C, D, E's, and that's where you have to start. Think about the toxidromes, because they may help guide you for some very specific therapy. And if you do get an organophosphate poisoning, don't be bashful with the atropine. And thank you again for all of you joining us. Bye.
Yeah, thank you so much, Dr. Harry. At this point in time, let's all turn on our videos so that we take a screenshot for purposes of attendance. And hello, colleagues, let's turn on our video so that we take a group pic for today's session. And on next Friday, 7th March, we shall have another session on cholinergic and anticholinergic toxidromes at the same time between 2 p.m. to 4 p.m. Thank you so much. Okay.
And for those who have been asking for how they can access the PowerPoint presentations, we always upload all the presentations that have been done in these sessions on our website. So you can just access. I posted the website on the chat. So you can always feel free to access those sessions on the website. And then in case you would like to also watch the video of the previous sessions, our YouTube channel is usually updated with the most recent sessions. So you can always feel free to watch them at your free time. We appreciate your consistency in this session, and we look forward to next week, and we hope to have a full room as well. Thank you.
Thank you so much, everyone. We meet on next Friday, 7th March, same time, 2 p.m., 4 p.m. About the cholinergic and anticoagulant toxidromes. Have a wonderful evening. See you soon.
Thank you, Dr. Harry, for the wonderful presentation, and good to see Charity, Mumza Charles, Sylvia, Secondo Okabo. Thank you all for joining. We appreciate your diligence in attending and getting knowledge out of these sessions. Amon Tukundane, thank you for joining. Charity from Barara, good to see you. Kilama Alfred, looks like you're from theater. We appreciate you taking off time in the middle of your work.